Welcome to this program titled the ASN 2025 Clinical Snapshot. Catch up with the latest in IgA nephropathy and the B-cell pathway. I'm Jonathan Barratt, a Professor of Renal Medicine from the University of Leicester in the UK, and with me is my good friend Richard Lafayette.
Yeah, it's great to be with you, John. Again, it's Rich Lafayette from Stanford University, a professor of medicine, and speaking to you from our Glomerular Disease Center. So it's great to be here.
Thanks, Richard. So B-cell therapies are closer than ever before to being approved for IgA nephropathy, a potential game changer for patients living with this disease. Richard, can you tell us something about the exciting data from phase 3 trials of B-cell agents that you saw and in fact presented in Houston at the ASN?
Yeah, it was really a fabulous meeting. Starting out, we were able to present the phase 3 Origin atacicept data. And again, it was just really, really great to see. This was a pretty standard phase 3 study, well-powered study of adult patients with IgA nephropathy, with more than a gram of proteinuria, with a GFR over 30, unstable background medication for at least 12 weeks of their RAS inhibitors, but more than half of them were also on SGLT2 inhibitors. And we were able to review the 9-month data, which had been previously released just by press release. But now we can see that it is true there was a substantial reduction in proteinuria by about 47%. There was a placebo reduction of about 6 to 7%. So the net reduction was 42 to 43%. Again, clinically really, really relevant and important and highly statistically significant. We're able to show that hematuria resolved in about 80% of patients who had it at baseline, that the galactose-deficient IgA1 had been reduced as expected from previous studies by about 2/3. And of course, we're not able to show the GFR data as that's part of the confirmatory evidence that will wait at the end of the 2-year study. We do know in phase 2, where there was similar, maybe a little bit more modest reductions in galactose-deficient IgA, hematuria, and in proteinuria, there was this beautiful stabilization of kidney function by the estimated GFR, and we're certainly hopeful that we're seeing the same. But we do know in a larger analysis of safety that patients tolerated the medication, once weekly subcutaneous injection of 1 ml. They did very well. Overall adverse events were similar between placebo and active therapy, that severe adverse events were actually numerically lower in general and including infections. And there was a little bit more injection site reactions, but patients thought they were mild to moderate and didn't stop therapy. So again, a wonderful, wonderful phase 3 progress report, and one that does lend itself to accelerated approval. And there is news that the company has filed for approval with the FDA initially. And so we hope that this will become available for our patients soon. And of course, let me pause for your reactions, and then we can talk a little bit about sibeprenlimab, which was presented later in the week.
Yeah, Richard, you gave an absolutely great presentation at the plenary session. I think the data for atacicept is really exciting. Perhaps one of the most exciting things after the fact that this drug leads to resolution of hematuria, reduces proteinuria and pathogenic IgA, is when we looked at that sensitivity analysis, it seemed to be able to function independent of many of the features we know are associated with poor outcome: high proteinuria versus low proteinuria, low GFR versus high GFR, whether the patient was actually on an SGLT2 inhibitor or not. And I think this was the first study really to have such a large number of patients on SGLT2 inhibitors. So it really speaks to the fact this drug is likely to be beneficial in IgA nephropathy patients of all shapes and sizes.
Yeah, and that's really, really exciting for the B-cell modifiers, because I think there's this implicit bias that we need to get them in earlier, when immune complexes are really first acting and inflammatory, but it may well be the entire disease course. And most patients we diagnose can benefit. We'll have to wait for more complete data from the entire data set. But yeah, it's looking incredibly exciting. And again, that's for BAFF in April. And for April alone, with sibeprenlimab, a blocker of April specifically with a monoclonal antibody, we had their early phase 3 results already reported at the ERA meetings earlier this year. And so that really nice reduction in proteinuria. But at the meetings now, Vlado Perkovic was able to show us that indeed that 9-month reduction in proteinuria was very nice with a net 50%. They were able to extend that interim analysis data out to 12 months, showing that there was continued improvement in proteinuria. And then they also were able to demonstrate very nice resolution of hematuria among those patients who had it in their baseline assessment. They were also able to show very nice control of galactose-deficient IgA1, which was great. And then thanks for pointing out in their sort of analysis by individual characteristics, they were able to show again if the patients were older, younger, higher GFR, lower GFR, on SGLT2 inhibitors, that things also looked promising. So we're really seeing these images of B-cell modification, whether by a really nice TACI inhibitor, BAFF-APRIL inhibitor in atacicept, or with a direct APRIL blocker in sibeprenlimab, that we're getting these really predictable, beautiful controls of proteinuria, hematuria, galactose-deficient IgA1, which from both phase 2 programs looks really likely to predict beautiful GFR control. We're going to have to wait for that data to be absolutely sure. But again, the sibeprenlimab likewise demonstrated a beautiful safety signature. They were able to also now advance to their entire safety subset at the time of the interim analysis, showing a balance of events, again, numerically more severe adverse events in the placebo rather than in the active patients on sibeprenlimab, less severe infections. And in the case of Sibi, the way they gathered the data, even the drug was well tolerated without an imbalance in injection site reactions. So really, again, very, very attractive data. As we know, we're waiting this month in November for the potential for an accelerated approval for sibeprenlimab. And I really do believe that these agents hold the promise to really, really change the landscape. And we've had so much progress over these last 2 years with targeted corticosteroids, with endothelin blockers, with complement inhibition. Some of them are waiting further data, but it's just so wonderful to have these non-systemic immunosuppressive, non-guaranteed to cause systemic side effect therapies available to us. And again, as I said before, we're moving maybe from this golden age to even a platinum age, and it's just so much fun to be involved in it. What do you think?
Yeah, I mean, I agree. And actually, I wondered whether you'd had any thoughts on the telitacicept data. So that's a study exclusively from China, but that's the first glimpse we had of a large phase 3 GFR effect, didn't we? And as you mentioned, we don't know the GFR effect for atacicept and sibeprenlimab. But what were your thoughts on seeing that data? Because that was pretty impressive.
Yeah, it was super exciting. And just for the audience, telitacicept is another TACI FC fusion protein that binds APRIL and BAFF very efficiently, had a really impressive phase 2 program showing reduction in proteinuria, hematuria, galactose-deficient IgA1, and stabilization of GFR in a very well-tolerated fashion. This drug's only being studied in China, but again, the data that they presented at the ASN, very, very impressive, 60% reduction of proteinuria, resolution of hematuria, most of the patients, stable reduction of galactose-deficient IgA1 without a worrisome reduction of IgG, similar to these other agents we're discussing. And they were able to show a net increase in GFR of just 2 to 3 millimeters per minute, but just spectacular to see that in this early analysis over the first 9 months, with the placebo group declining in GFR as expected. So just fulfilling all our hopes. Again, even for telitacicept, we need to see more mature proteinuria, GFR data, safety data, but taken all together, just looks like you can walk on the clouds now and say that these agents are going to do exactly what they were suggested to do from their development from phase 2, and the phase 3 data is fabulous. We can fill that in with again, early, while the phase 3 study of povetacicept is in place, yet another TACI-FC infusion with a little bit more tinkering in the hope to give it a longer half-life and more tissue penetration. That likewise, the proteinuria reduction was amazing. Hematuria reduction looked good. A little hints that in membranous, this pathway may work as well, and with great safety. So I think, again, it's just unbridled excitement. You almost are just waiting for something to counter the enthusiasm, but I really think we're going to get away unscathed, and this is really just wonderful.
Yeah, so I mean, as you say, both APRIL only and BAFF and APRIL agents, outstanding data presented. The Ruby 3 data you mentioned from the early phase study of povetacicept, and now we've got 3 phase 3s reporting. But the story doesn't stop there. So we think we've got this disease covered with BAFF and APRIL, but actually we're seeing emerging data now come from CD38 depleting antibodies. And we all know these drugs and their use in multiple myeloma. Many of us will be looking after kidney patients who've been treated with daratumumab, for instance. But we now have 2 monoclonal antibodies that are being evaluated in IgA that specifically are targeting CD38 positive cells, predominantly plasma cells, and those are mezagitamab and felzartamab. And for the first time, we saw long-term data with mezagitamab in a poster presentation. And this looked at outcomes out to 96 weeks with an initial 22-week treatment cycle and then 74 weeks off treatment. And what was astounding about those data, it was a small study, it was uncontrolled, is that there was persistent suppression of proteinuria for the full 96 weeks. So 60 plus weeks off treatment and proteinuria didn't come back. We saw stability in GFR over that full 96 weeks. 60 weeks off treatment, I'm going to keep saying this. And we saw suppression of Gd-IgA1 again for the full period, 60 weeks with no treatment. Something that, again, we didn't think we were likely to see. And one of the really fascinating things about that study was that the total IgA recovered, but the Gd-IgA1 didn't, suggesting that CD38 depletion is impacting on those cells producing the pathogenic IgA in a different way to the plasma cells producing normal, presumably just monomeric IgA. So this offers a tantalizing view of where we might be moving to next in terms of depletion strategies. We'd already seen the data for felzartamab presented earlier in the year in Europe. We had some very interesting biomarker analyses presented at the ASN, looking particularly at transcriptome patterns within circulating PBMCs in the felzartamab phase 2 study, starting to give us an indication of the pathways that CD38 depletion might be impacting upon that could be relevant for IgA nephropathy. And both felzartamab and mezagitamab are now being evaluated in phase 3 studies, and we saw their study design for the PREVAIL and the OMEGA studies, both looking at, in a traditional way, at a 9-month proteinuria outcome and a 2-year GFR outcome, but really looking for a persistence of response beyond treatment, which I think is going to be fascinating to see in a larger study. So, Richard, I am very, very jealous of you, because in less than 3 weeks, you're going to be able to prescribe sibeprenlimab, hopefully. And I'm going to have to wait 2 or 3 years. So where do you think these therapies are going to fit in when you see that patient coming through the door with a new diagnosis of IgA nephropathy?
Yeah, I think it's just wonderful times. As you know, for me, looking at KDIGO guidelines and what our patients need, I think for patients with mild, moderate disease, if we can get their proteinuria really, really low, with any of our agents, I do think patients will do really well. But I think for those patients at more moderate high risk, where our supportive therapies are less likely to get them to goal or keep them there, that these B-cell modifying drugs really look the very best of anything we've seen. Again, we need more mature data. It's super exciting what you said about the plasma cell drugs, that you can give one and done or just intermittent therapy would be super exciting. But personally, I do see that I'll be leaning on these B-cell modifying drugs, first sibeprenlimab and soon thereafter atacicept, a lot to keep my patients where they need to be and really start down that path that you've championed so well to really think about a lifetime without progressive kidney dysfunction or kidney failure. We're nearly there.
It's going to be fantastic. And I can't wait to the next conference and the conference after that, because we're going to see more and more and more data. And that's what we want to see, isn't it? So thank you very much for listening, guys. And it's been a real pleasure to be joined with Richard to talk about the ASN highlights. Thank you.
Cheers. Thank you.